Very good. Thank you very much, Anita. So now over to um, over to questions, Sir Richard.
Yes, thank you, Anita. And I'll need some help. I'm learning fantasy impromptu at the moment, so any tips would be great. Um, question number one is around IP. So, what parts of the procedure have patents slash other IP? Um, so the patent portfolio at the moment, the initial patent is around the shape of the catheter, so the geometry. So that's really where the project started was attempting to make it much easier for the operators to maneuver the catheter around the inside of the chamber. So the earliest patent is around the geometry, which is currently going through PCT. The second provisional patent that's been filed, and I feel is probably the strongest one, is around, I mentioned the optimized electrodes. So we're currently using this pulse field ablation technology, which is very early, very new, and they've already spotted some issues with it. And a lot of companies have simply taken off the shelf catheters and fired pulsed field through them, and they've realized the way the metal is shaped um, is not ideal for handling very high voltages. So actually, we've created some very purpose-built electrodes to deliver PFA more effectively, and that's taken up a lot of our time to get that right. Um, and then also, yeah, so lots of aspects around the geometry of delivering PFA. So I'm sure some of you will look into pulse field and you'll see it. I mean, it's exploding that market, 30 odd percent CAGR at the moment. Um, yeah, so around IP at the moment, there's one PCT, two provisionals, and we're looking to put a third provisional in the next few weeks on a new electrode design as well. Next question: is there a minimum investment for the remaining 50K? Yes, we've asked for a minimum ticket size of £10,000. That's been consistent for everyone that's participated so far. So £10,000 is the minimum ticket size. Next question. What are the risks involved before the device can go on sale? Um, that's a jolly good question. I'll be brutally honest. Half of the answer I'll have to rub my crystal ball to tell you. But what I do know is, with catheter ablation technologies, we're already playing in a relatively safe space because it's minimally invasive. We're using extremely small 7 French, very small catheters that go through the groin of the patient. And then we'll be puncturing subxiphoids to introduce that second catheter. And these are all techniques which are extremely familiar with the doctors that we're working with. So, I mean, really, the risks are involved, to my mind, is just around the manufacturing and ensuring that we don't, the device doesn't disintegrate or extremely basic things around that. But I think we found a very good partner in London for our manufacturing. Um, so next question, can I explain some more about the hybrid operation? Yeah, so hybrids at the moment, when you talk to a doctor about hybrid ablation, they think of it as sending their patients to the surgeon first, and then the surgeon goes in and performs their ablations on the outside of the heart. Then they, again, very invasive. Then the patient's woken up. A few weeks later, they come back and then they see the electrophysiologist. And the electrophysiologist goes in from the inside of the heart. They sort of assess how well the surgeon's done, and then they touch it up from the inside. And all of the randomized controlled trials around this technique are superior. They show superiority in doing the outside and the inside. But again, the big downside to this is that it is, once again, two separate visits for that patient to come in. And we are aiming to turn this into one operation where the electrophysiologist can do the outside and the inside in one operation. So the next question is, can you say a bit more about how the money is going to be used? and what will have been achieved before you go to raise more money? Yes, good question. So this money, I'd say, when I say we've been capital efficient to date, I think that's a very fair comment. If you compare where we are with the money we've raised so far, we've gotten quite far down the track. I'll try and segment what we've done so far. So the project really consists of three main categories. There's the inside catheter, there's the outside catheter, and then we're going to build our own generator to deliver the pulsed field ablation. So the majority of the money so far, I'd say that we've raised so far, 80% of that money has gone on the inside catheter. We've already started working and we're almost finished design freeze on the outside catheter. Now this money is very much focused on building the generator that will deliver the energy through the catheters. So that was always the plan from the start. You build your catheters first, and you establish the geometry, the shapes of the catheters, because then that dictates, what the amount of energy that you need to push into it based on the size, the shape, the positions, etc. So yeah, as I say, very clear. It's phase 1, 2, 3, with a third being the generator. And this, as I say, this cash is very much focused on generator and sort of bringing all those three aspects together. To date, we've essentially been using off the shelf, and over time we're slowly swapping the off the shelf for our own solution. So next question, I didn't mention cardioversion and how that fits in. Oh yeah, great question around cardioversion. So yeah, I think when you go and see your GP, and if you systematic AFib, yeah, you can get sent into hospital for a cardioversion to try and restore a normal rhythm. Now, I didn't really have time in 10 minutes to really describe to you all about atrial fibrillation, but I'll try and give you a 30-second lesson. Atrial fibrillation is on a spectrum. You either have paroxysms of atrial fibrillation where it sort of comes and it self-terminates. Now, those, if you go for an operation for paroxysmal AF, that is highly successful, and that's very well served. We're focused on the other 50% of patients who have persistent AFib. Now, persistent by definition means it won't self-terminate, and you either have to go and have a cardioversion or an ablation to bring you back into sinus rhythm. So again, if you've got persistent AFib, it basically means your heart is already very scarred. Lots of people have a cardioversion, and then probably about 6 months to a year later, the AFib comes back because you haven't done anything to the substrate of the heart. By cardioverting a patient, you've not physically removed the reason why that patient has gone into AFib in the first place, but it does give you, a sort of a year, if you're lucky, six months to a year of normal rhythm. But yeah, cardioversion certainly sits in that mix of the 98% of people that are offered either a pill in a pocket or potentially a cardioversion, and then ablation is the last, the sort of last attempt. There's a company called Rhythm AI for targeted ablation. Yeah, great question. So I mentioned in on one of my slides, my last company was a diagnostic AFib company. We actually did a lot of work in St Bart's Hospital in London, where I got to know Professor Richard Schilling quite well, and I know Prof Schilling, his Rhythm AI work. So I spent 8 to 10 years looking at diagnosis of atrial fibrillation and looking at maps of AFib, and the diagnosis is all well and good, but it ultimately always ended up with the operators delivering pulmonary vein isolation, which is the cornerstone of AFib ablation, So the operators always do a PVI, and then after that, typically they end up doing linear lesion sets to try and terminate atrial fibrillation. So they would go from a vein to a valve, for example, and they talk about it as compartmentalizing the heart. So one of the theories for AFib is the heart gets stretched and old and gets bigger and bigger and bigger. And the bigger it is, the more likely it is to fibrillate. So Dr. James Cox in the 1980s realized, well, actually, if I take a scalpel and cut it into much smaller pieces and stitch it back together, compartmentalizing the atrium, suddenly the patients went back into a normal rhythm. But obviously extremely dangerous. Quite a few patients died, unfortunately, on the table with that procedure. So my firm belief is with ChamberTech, with this device, we can get the same results as what Dr. James Cox was getting in the 1980s with his scalpel, but simply we're doing it in a safer electrophysiology procedure with, again, catheter on the inside, catheter on the outside, sandwiching the tissue. But yeah, there's Rhythm AI is a company. There's another company called Volta. Acutus Medical was my previous company. I'd say that there's a number of the AF mapping companies out there. Tapera, unfortunately, was acquired, but then was put on the shelf. Yeah, it's a personal opinion, but I think I've seen enough of AF mapping to understand that actually what we need to focus on is therapy, not simply looking at nice patterns. Oh, sorry, and then it says, are they competitor or collaborator? Yeah, it could be, diagnosis and therapy are two separate camps. There's absolutely no reason why an operator might say, well, I'd like to look at the atrial fibrillation, doing some diagnostic work, and then let's treat it with ChamberTech, because, I know that delivering linear lesion sets is the strategy they want to adopt. So, but quite honestly, I would, in my opinion, and the doctors I've been working with for the preclinical work here, I think the quickest and most efficient method is to get the patient in, isolate the pulmonary veins, and then deliver this basically a Cox maze lesion set, but using catheter ablation tools. And just get the job done and get the patient out of there in a couple of hours in the most safe and effective manner. And that's
it.
That appears to be the bottom of the
question. Okay. Well, thank you, That's the end of this presentation. And thank you very much, Richard. And thank everybody for coming. And all the documentation you need to actually make an investment is available at the link you've been sent before the meeting. And we'll see you next month.